services for the Mental Health Association in North Carolina, which, with all of the shifts in the public mental health system, had, along with Easter Seals and other advocacy agencies, taken up delivering services. She needed somebody to cover for, well, first it was a day, and then it was 2 days, and it was in Salisbury. Well, it's down in the middle of the state there somewhere. So at that point, I was doing weekend coverage, 3 weekends a month at Baptist, which was great. It was a wilderness lake during the week, except I didn't have a boat driver, so that wasn't so good. So on some of those days, I went down there for a while, and then in 2006, got both feet back over the mountains and went to work with MHA as their medical director for enhanced services. During the time that I had been gone, and here is where there were slides with a bunch of these events on them and such, but they disappeared when I closed the program the last time. The North Carolina General Assembly in 2001 took their first step in reform, which was to require the local jurisdictions to separate the management of mental health services from the delivery of the services. They would then contract with private providers to provide those services, and they would manage the service. I'd been aware of this to some extent because attending the North Carolina Psychiatric Association and talking to people, there were these rumblings. And at one of the meetings in 2000 or 2001, some legislators had come to our annual meeting and were holding an open town meeting sort of thing about this. And at one point, one of the psychiatrists asked them something they really hadn't considered, which was, what makes you think there are private providers who want this business? And as far as psychiatric services were concerned, there weren't many. So first they went through all of this divesting of clinical staff, and then they had to backtrack and try and hire some of the psychiatrists back into the system, which didn't work really well. Then in 2002, the state contracted with Value Options to do prior authorization. So that left these local management entities, which had been area programs, responsible for contracting with people to provide the services, but with no control over the money. And they actually continued that contract up until 2013. And that did not work very well as far as the budget was concerned. Problems with the privatization from the start. They lost a lot of highly trained mental health care workers. The system became amazingly fragmented. Previously, there was the area program, and they had the outpatient clinic and whatever outreach services they had, which weren't a whole lot at the time, and the PSR and such. And we could sometimes have people in more than one of these services, even though only one of them is being paid, because the money all went to the same place. And now you've got one entity doing the PSR, you've got us doing ACT, you've got somebody else doing the more basic outpatient clinic and mobile crisis, and everybody gets paid separately. And of course, if someone is receiving ACT services, ACT is to provide everything, and so they don't pay for anything else, which makes life interesting. So there was the fragmentation, and then a lot of the private corporate folks noticed a very good opportunity Community support was set up without much management and without much authorization. And of course, that is a service that can be delivered with people without much training or no licensure or whatever. And there was a tremendous amount of community support service delivered in North Carolina, which really busted the budget pretty good. And also, there were a lot of people not getting services, and just like everywhere else, people started ending up in emergency departments and in jail. So anyway, as I got back in 2006, although we didn't have the state system, a lot of the professionals had joined these various private entities or had set them up and did the contracting. And it was, well, not exactly like whack-a-mole because there wasn't a conscious whacking, but they'd pop up and go away and pop up and go away. And there was an incredible turnover of agencies. A lot of the professionals moved from this one to that one to the next one, but not necessarily with any continuity for the people they were serving, and so everything was a mess. It's still a mess. So anyway, it turned out that a couple of the ACT teams with MHA had also been people who had worked with Foothills, and so there was actually some continuity there. And also, in that particular area, I don't know what the populations are in the various places, but there can't be more than 30,000 people in McDowell County, and there are probably some more than that in Lenore and Caldwell, but they're probably less than that over in Alexander. There's one little town, Taylorsville, and the rest of it's farm and woods. The people who had been in the system, both as clients and as providers, had long roots there. They stayed there. They were still there in these various other places. And the contacts with them allowed us to negotiate various services in different ways. Plus, like some of the people on the Morganton, on the ACT team that did that four-county area, had worked at the state hospital in Morganton, and they'd worked in the outpatient clinic, and they'd worked in and they'd known some of these clients for 30 years, and it was impossible to get records. With the area program, at least you would get this chart, and sorting through it to find the important information wasn't always easy, but at least it was there. Where they all went with the divestiture and the balkanization and such, nobody seems to know. It's, you'd think if somebody's been in the system for 20, 30 years, there would be records somewhere. You wouldn't have to start anew each time they came somewhere, which is interesting. Of course, the electronic medical record is going to fix that, except it's all check boxes and there's no information anyway. And people still think HIPAA means you can't give anybody information, rather than you just have to tell people that you're giving everybody their information. And North Carolina legislature actually passed a law reinforcing that for anyone, how did they put it, for any entity that is receiving Medicaid funding, not can, should, better, communicate with any other entity clinical information about a client for the purposes of treatment, whatever. And entity is designed as if you happen to be a solo person in practice somewhere, but you're getting paid by Medicaid, you are that entity, and that the hospital or whoever should just send you this stuff. It ain't working. So, the way that we did things at this point on the ACT teams was a little different. Nobody saw anybody in the office unless they happened to live next door and dropped in. There wasn't anywhere to see them. And the setup is basically there's a large morning meeting room which has got the board with the people on it and who's been seen and who's being seen and the list of what needs to be done and a bunch of chairs, and you sit down in the morning with the team and go over who got seen and comment about what was going on the previous day, what's going on today, what the crises are, who's going to do what, and people get their assignments and hit the road. And the psychiatrist then would generally go with one of the team members. Well, for me, I was going down to Salisbury, which was north of Charlotte, and I didn't know my way around there at all. But there were at least 2 psychiatrists with each of the teams, each of us working like 2 days a week. And so we weren't there for every morning meeting, so we didn't have the same continuity you'd get from that. And so having somebody go around with us was good for several different reasons. One was there'd be some opportunity for education, talking with the person, some one-on-one with the staff people. We tried to rotate the ones we went around with. We could also get some idea what was going on with the team dynamics, maybe, that we wouldn't just getting to a couple of morning meetings. And besides that, I didn't get lost, which was very useful. During that period of time in the turmoil in our little corner, in 2006, the Burke County Commissioners, in the middle of this 4-county, decided that they had had enough of Foothills, and they moved over to the Catawba local management entity, which left Foothills with McDowell Caldwell and Alexander. One of the major pieces of this 2001 mental health system reform well, I'm not sure whether it was then. It was certainly in 2005 when they did the next big reform bill. And let me see if I find that one. This was all about the 1950 BC waiver program, which under that program, states can set up, it gives them more options, things they can do with the block grant money, one of which is to set up managed care organizations. And this in the initial, I think, 2005 or 8 or somewhere in there, the idea was, and I had already been, that all of these little 4-county or 1-county or whatever area programs would begin to merge into larger entities. Well, Foothills was obviously not in a very good shape with 3 counties having lost their main center of population. But there was all kinds of politics going on with the whole thing. What that meant for us, we now had been having to contract with multiple different LMEs because we saw people in multiple different places. And in North Carolina, with this whole thing about people ending up in assisted livings, this area of Western North Carolina seemed to be where everybody rolled downhill to from elsewhere around North Carolina, as well as around South Carolina. If they burned all their bridges in Wilmington and those counties and no other place would accept them, well, they came out to Buncombe or McDowell County or some of the other assisted livings in that area. Those people were not at that point considered residents of that area, and so their funding did not come from that area. It came from the home area, which is also who you had to contract with in order to provide services. And we were, there were, obviously, if they couldn't stay anywhere and they couldn't stay out of the hospital and they couldn't even maintain housing in an assisted living, they needed more intense services than every 3 months medication check. And there, at that point, wasn't, and there still really isn't much anything in between that every 3-month visit and ACT. So we would see a number of those people, and we still do. So when Burke County moved over, that meant that we had to contract with the Catawba LME for the people who were in that county that we were seeing. And then in 2007, Foothills went away altogether, and those 3 remaining counties were picked up by what was then New River, now LME, which was up here. And that went along for about a year or so, maybe 2. About 2008, I stopped going to Salisbury and started going to an ACT team that was in Buncombe County. That team had started back when Blue Ridge Mental Health Center and the area program was running things. I think 1995 was when it first became, when ACT first became a billable Medicaid service, and so they had started this and some other teams. Then with the divestiture, the separation of management from service delivery, a large chunk of the clinical people of Blue Ridge set up New Vistas. And that worked well for about 6 years. And in 2008, New Vistas went belly up, which lots of places were all over the place. This was a pretty good-sized one. But the team stayed intact. The people they were seeing were the same people they'd seen back under Blue Ridge. And they came under the umbrella then of MHA. And the only issue there was I started going up there and working with that team because the psychiatrists there still were staying in the office and not getting out and seeing people, and everybody else had to make up the 70–85% of the visits, and it just wasn't how it ought to be. And so things went along relatively smoothly. I was now as close to home as I'd been since before Island closed, working pretty much in the neighboring counties, and that was okay until 2010 when the Mental Health Association went belly up. That was a surprise. I thought if there was any organization that was going to keep going in the state, that would be it. Well, this wasn't the total organization. This was just the service delivery piece of it. But it turned out this was the second time in 40 years they'd gone belly up. This time it was because they weren't paying the IRS, and the IRS just really didn't like that. About that same time, New River went away, and as you see that big blue area there, they got picked up by, the tail of the state was Smoky Mountain Center, LME, now MHO, and they picked up what had been Foothills and what had been New River. Western Highlands was that green thing in the middle there, between of the blue. We were already contracting with Smoky, so it didn't make a great big difference to us. Then the legislature said, okay, they started, with the waiver, they started down in the Charlotte area, this demonstration project of managed care. Medicaid managed care. They did well with the money management and delivery of services. So in 2010, the legislature says, okay, 2 more places need to do this. About that time, also, the Affordable Care Act passed, and that left other options to look at in the broader area. The whole community support and the cherry-picking thing also had raised questions about quality of providers throughout the state. Well, the department and the legislature, the Department of Health and Human Services said, okay, we'll just make a new provider classification, and they got another piece of alphabet soup, CABAs, Critical Access Behavioral Health Agencies. This was to try and get all these little pieces to coalesce together into some larger pieces, not unlike a mental health center had been back when. They were to deliver, they could be profit, nonprofit, or whatever, but they had to provide 3 core services: comprehensive clinical assessment, medication management, and outpatient therapy, and at least 2 other services from a list of 14. Substance abuse services, ACT, community support team, things of that sort. Also, they required, because of this quality thing, that CABAs have a medical director. And it had to be a full-time medical director if they served more than 750 consumers. And they had to have a clinical director. And they had to have a quality management and staff training director. It had been a long time in community mental health in North Carolina since psychiatry was involved in the line operations. And so for about a year, this looked like, well, maybe there's some way we can get our foot in there and do some things. Well, the history of mental health reform in North Carolina is constant change, and the rules are changing every time you turn around, and they changed again. But the main thing they did was they left out any funding for the medical director. Meeting with Western Highland at one point, we were told that there was enough padding in the enhanced services payment scheme that these LMEs, once they got to be in charge of the money as MHOs, their task would be, as they managed the funds, however, first they had to put aside a pot for contingencies, and after that they could use the money to do other things, like medication management has always been a money-losing proposition there. I don't imagine it pays any better here. And so all of these other things would be, that's one of the things PBH, the pilot thing, had done. They'd actually paid people enough to cover their costs for doing mental health, medication management. That was fine, except then the state said, okay, we're going to do the waiver statewide. And their idea was, we'll improve access to mental health, developmental disability, and substance abuse, improve quality of services, improve outcomes, improve access to primary care for people with mental illness, improve cost-benefit of services, and effectively manage all public resources assigned to the local management entities. The last presentation I attended by one of the state educating us as to all the wonderful new things that were happening, it was a consultant from Nashville, actually, who was working with one of the new management entity conglomerations. And so they had, when the state had said, okay, we're going to do this, they also cut the budget. How they cut the budget wasn't clinical, whatever. They just didn't send the money to cover the administrative stuff for the MHOs, along with the rest of the package, which is about a 20% cut. So the guy was saying, you know, it doesn't work to try and cut payment to providers anymore. It probably isn't going to work. A lot of them are so enthused as it is. We can't treat less people, so we're going to have new and better ways to deliver more for less to more people. Wonderful. Nobody said how. And this was all supposed to happen over the next 3 years. The LMEs, which were already conglomerations of various of the area programs, had minimum standards they had to meet in order to become an MHO. If they didn't meet them, they would have to be swallowed up by one of the others, and as had happened with Foothills and New River. Started with 23 LMEs, already down from the 42 area programs, and it was their expectation that by the end there'd be 8 to 10 left. And we're heading along that direction. So then in 2012, I've forgotten which group it was, advocacy group, filed a complaint with the Department of Justice that North Carolina wasn't doing what Olmstead decision said they ought to do. And the Department of Justice agreed with them. And so there is a settlement with DOJ that's in one of these slides that's out of order here at some point about all that they're going to do to get people moved out. And one of the main ways they were going to take care of them was with ACT. Well, that's nice. Not all of those people necessarily meet criteria, I don't think, but we'll see what happens. An issue direct, let's see. Okay, I did say MHA went belly up. We moved about half of the teams, the clinical director and myself, to come under the umbrella of a relatively new private provider organization, Strategic Interventions. And pretty much kept, the Buncombe team was amazing. They had the same, not exactly the same staff, but the same core staff, serving a lot of the same people through four, now in their 1, 2, 3, this was their 4th different umbrella organization. Most did not go that well. But there had been an issue for a long time with Western Highlands, with some of the folks that, and they have a point, we shouldn't be taking care of people in these facilities. These facilities should be closed, done away with, and such. And the DOJ sort of thinks so too. Somewhere along the line, somebody had made the wise comment that in the process of closing down the hospitals, of course, facilities and services need to be developed in the community in order for these people to be taken care of, and obviously you can't close the hospitals until you get that done. Well, that was wrong. One of the things I was looking at actually said that I had not thought this was true, but that it actually costs, maybe this was in Texas, it costs $20,000 a year for a non-mentally ill prisoner and $30,000 for one that's mentally ill. And that's still about 10% what it costs to keep them in a state hospital. And so it was a cost-effective solution. Anyway, so Western Highland did not particularly like the fact that we were serving some of these folks. And when they qualified in 2012 to become an MHO, of course, then they could select which providers they were going to work with. No fault, no whatever, they could just have. So they said, well, we're not going to work with you anymore. Well, that was exciting, except that half of our population in Buncombe were covered by other LMEs, so we were still doing things up there at that point. And that was a little bit tense for about 6 months, and then Western Highlands went away. And let me see. That was Western Highlands. Color that blue. So Smokies pretty much got themselves set for the western end of the state. Now they just have to figure out how to survive financially. So that has made continuity for me at these various places and teams interesting. And it has been fortunate to maintain as much of it as we could. Funds are tighter. Instead of going around with a staff person these days, I go driving around myself. And it is rural. I don't always have cell phone connection. Therefore, the map app doesn't always work. And so I do get lost. And that is not very cost effective. But I have learned about places in with the teams I'm working on at the moment. It's McDowell County, Rutherford County below it, then over into Buncombe, and sometimes down into Henderson County, I think it is. We have a team in Morganton over in Burke that does the upper leg around with Alexander and such. There's another one in Yadkinville, another one in Greensboro, and one up in, I think, Guilford. That's Greensboro. One up along the border there. So we're a small entity that does almost entirely ACT, but we did qualify to be a CABA when it looked like that was going to be important. A year after all that went through, then they de-emphasized the whole thing again, and you don't even hear about that anymore, which is much the way things have gone. There are some things that I have certainly learned, and some interesting patients I've seen during this time. And does everybody here know what ACT is? Any of you work on ACT teams? No? It's, yeah, I worked for 17 years in a private psychiatric hospital doing intensive treatment with people that you could talk to them, you could work with them over an extended period of time. Very interesting and not at all like the short-term in and out sort of thing. Was much less satisfying doing hospital treatment or the private practice. This is probably even more satisfying. Well, it has many of the same attributes that Highland did. The idea is to go and evaluate and get to know the people and work with them and try and figure out what's going on, and you work with them over time. I get around maybe once a month on average, but there are people that I go around and see more often. And I spent 3.5 hours the other day with this new guy, just trying to figure out what was going on with this. It's one of the things that you're supposed to do. There's not the lockstep, do it this way. Plus, you're not in an office, and you get to see some very interesting places. Some of the interesting places were on the pictures of the slides that disappeared. Sorry. So I guess I'd better say something briefly about what ACT is. All right, we did that. So it was developed as part of the deinstitutionalization process as a hospital without walls, and it seemed to work. There are standards which were initially developed and that have been modified. Interestingly, one of the measurement ones by Dr. Moser, psychologist, well, wrong button, anyway, she's in North Carolina. And that these are out of order, we'll do them as they come. How many do you need? One study said enough for that there's about 50% of your population of SPMI. Others are more like 20%. It only is cost effective when you're serving the right people, and so that's important. This NC Act coalition is out of order, but this is a group that is, again, Dr. Moser in there, working to teach people how to do ACT, how to maintain fidelity to the program and such, and that there is an interesting aspect to that. They are also involved with the DOJ settlement as part of the evaluation of all the programs to make sure they're doing things right. So they're both training us and evaluating us, and it makes life interesting there too. Because one of the persons who developed the scale is actually the one who's administering the scale, and it does have some opinions. One of the things that the DOJ settlement has brought is this InReach program, in which the LMEs are sending folks out to all of the different facilities, interviewing everybody, trying to see, okay, who can we move out? And their job is to try and move them out, which is great, except for those that go into a panic because, as with the state hospitals, oh my God, I can't make it out there, don't do that to me. Or those who get confused and think they're going to be out on the street and various other things. It was not handled exactly smoothly, but there are a few people that we're working with that this has provided some additional resources to, that we've gotten them out. And ACT is a big piece of that. And so these folks are involved in doing all of this. Program fidelity is a big deal because in terms of all of the studies that have done, and for an evidence-based practice, you have to follow the requirements of the treatment for the treatment to work. At least that's the assumption. A big part of ACT is going at things from a recovery mode, and I'm sure you've all heard lots about recovery, which is to live a fulfilling and productive life despite a disability. The villages out in, I think it's San Diego, there is, that program has been going on for quite a while. And Mark Raggins, the doctor who helped found it, it's one of the models for a community-based, very community-involved program. They do ACT teams there, but mostly they have 3 centralized places. They have a lot of services there, and they have a lot of outreach to bring people in, and then they go out to see people. But it is the sort of thing that I have heard programs in Baltimore get gigged for because they've got too much going on in their building, not all in the community, for the ACT team, which, yes, that's the way the ACT team was designed, but they have a tremendous program. He gave a great example of what is recovery. You got an NFL running back, he gets a nasty knee injury, he gets surgery, he does rehab, he gets back the next year, he gets back to his position, but he doesn't run the same way that he used to. His knee isn't the same, but he's functional in a different way. So that's recovery. Focused on wellness. Doesn't mean an absence of symptoms. You're not cured. The core elements of ACT, it's a team approach, multidisciplinary, it's done in the community, flexible, boy is it flexible. ACT is the point of responsibility. We are in fact the designated medical home for some of our people. 24/7 service, and at most a 10-to-1 ratio of staff, and time unlimited. The early studies, people who were in ACT over a year and then stepped down. They deteriorated within the next 6 months. We're back in and out of the hospital. And the same thing happened after 5 years. If we are serving the people that we're meant to serve, they're people who need this service. They're the people who actually ended up having to live in the hospitals before. SPMI, schizophrenia, schizoaffective bipolar, and that it's bad enough that they can't make it with the less intensive programs. And driven by consumers' goal, Dr. Reagan had another good one there. There was a chronically psychotic guy. It sounded like he was a street person, but he may have been living, I don't know, in a rooming house or something. But he wouldn't take medication, and he was pretty crazy, and he was pretty disheveled and unkempt and whatever. But he got the idea he wanted to date. He was having trouble getting dates. And so they were talking to him and helping him. How do you deal with clothes? How do you deal with hygiene? And it might be easier for you to keep track of all of this, maybe if you try some of the medication. Well, he did. It did. He started to date, and he decided maybe he'd stay with it. So that was an interesting way of meeting him where he was on his goals. I saw a guy present who is a NAMI, works in one of their programs for the families of people in the early stages of being diagnosed and all the trauma of treatment and all this sort of thing. He had been a non-adherent in and out of the hospital, severe bipolar psychosis, until he started taking his medication regularly, and he at this point has, I believe he's married and is on his pretty close to his PhD and regularly employed in his work with NAMI. I have always wondered, because there are people over the years that they get it and something happens and they start doing better. Either be taking their medication or they're not cutting themselves anymore, various kinds of things. I always ask them, what happened? Sometimes they tell me something I said or did that that was very important to them, which had nothing to do with anything I ever thought was important. So, like anything else, we think we know who's taking their medication and who isn't. We don't. And we think we know what's important to them, but it turns out that to them it may well have been something else again. Anyhow, with him it was a woman too. And so he started on medication regularly, developed a relationship. I think they might have even gotten married, I don't know. But as he said, it was fortunate that he liked it that way because he stayed on the medication, even though he's had several other, I think he's married for the third time or something like that, I don't know. But once started, he didn't give it up just because the relationship blew up. I don't know how we can be evidence-based if we're always changing. I'm also not sure that with evidence-based practices that we know all that we think we know. Dr. Akiskal, who is another old fart like me, who has worked a lot in bipolar, was presenting at one of our meetings, and he's wandering around the front of the room and talking about something, and somebody says something about evidence-based practice. He says, evidence-based practice, yeah, for 2% of the population. Anyway, this is an evidence-based practice. There are a lot of empirical studies and meta-analyses and such, and it's got lots of endorsements with decreased hospital use, more independent living, housing system, retention, etc. There are also some people who say it doesn't show that, and if you look at the data closely, you can't say that, and there's nothing that says it's not just a lot of people paying a lot of attention. These people, period, that's doing this. And so there are those who have a different opinion. Sort of like with the BT program, the Marshall Linna's manualized treatment. That whole book, manual, everything, was based on a study with 33 patients. And that wasn't a huge volume of data. So you got different size teams, small, 50, medium, up to 75, no more than 120. Rural teams, well, they say we ought to be small to mid-size, yeah, we're around about 85. It gets more than that, it gets real exciting. And you should only have a few people in and out at the same time per month. But you know, if you lose a bunch, if you got to keep the staff, you're going to have to get more people in, or you can't make payroll. The idea is that there's less burnout, which may be true because you've got a lower caseload. There's a strong team approach. You get a lot of support and interaction. Every morning the team meets, talks, whatever, and along with going over what's going on for the day, you also get to talk to the people about this, that, and the other, see each other's faces. So it does, what does it do? It does everything. So some of the things that I've learned from doing ACT have been kind of interesting, one of which was about exploding head syndrome. Run into one of those yet? Totally by accident. I was talking to this guy in his trailer, and he's talking about this that's going on. A couple of times I see him. I have no idea how this happened. It's one of the positive things from Google. Maybe I just typed in exploding head. It popped up as a parasomnia that's studied, actually. Nothing to do about it, but it was not dangerous, and he was really glad to hear about that, which I thought was kind of interesting. There have been a couple of people that have, over the course of things, two of them ended up with the Zyprexa payout. That's a problem if you're on Medicaid. So I got to learn about, they were special needs trusts at the time. They're called something else now. So these people could get these set up before somebody gave them a check so that they wouldn't have to immediately pay it all to government. Even while at Highland, I had been one of the most positive long-term outcomes I had ever had. Not I, but that I had been part of. This young man came at the age of 19 from Ohio to Highland, and he was fetal alcohol syndrome in retrospect, but he also was schizoaffective, emotionally labile, violent, reactive, severe PTSD. He'd been in and out of state hospitals since he was whatever. His father was abusive. The state hospitals were abusive. Got his arm broken a time or two, things like that in treatment. And over the period of a year and a half, he gradually got contained enough behavior that in partnership with Blue Ridge Health Center, we had started Mountain House on the model of Fountain House in Nashville, and he was one of the early folks there with the actively supported appointment. Somebody went with him to Ingalls at night, and he was pushing the broom around and whatever and such. And they had a little rooming house across the street where he could move into. And then he went on with wherever he went on with that. And about 5 years later, he comes in with a Jehovah's Witness man from the church. He had gotten hooked up with them, and it was a very positive situation, very supportive and such. But he had gone from Ingalls. He was working at UNCA in one of the dormitories. He was one of their best employees on the janitorial staff, and he was getting married, and he needed me to sign something to get life insurance. I saw him again 10 years later. Unfortunately, his wife had turned out to be bipolar and didn't want to take medicine, and that relationship had ended. But he weathered that, continued to work with his job, and is still, as far as I know. So I thought that was a pretty good example of how it can work. I see some of these programs that say they've got a large proportion working. I also see a small percentage of people with this illness employed, and that doesn't square. I don't understand quite how they're doing it. And they sure aren't seeing the people I am, and the people that I'm seeing sure don't fit the model for dosing and one neuroleptic fixes it all. But I guess they're all outliers. Oh, it's over time. I'm sorry. I wasn't watching. Thank you. Any questions? I'll be glad to. Sorry to keep you past lunchtime. I like this as much as anything I've ever done. Try it.